I'm Kieran Anderson, group publisher here at Applied Radiology, and today I'm joined in the booth by Dr. Prashant Nagpal and Dr. Peter Noël. Thank you both for joining me. We're going to be talking about the future of CT imaging and where advances in, detector technology, AI, photon counting CT, all of this new stuff on these, the scanners, these designs, and how they're really reshaping what's truly possible in diagnosis, workflow, patient care. And for that, the two of you are coming to this table with a lot of experience. Dr. Nagpal, you're a professor. You're also the section chief of the cardiovascular imaging at UW Health in Madison. That's correct, yeah?
Yes.
And Dr. Noël, associate professor of radiology at the University of Pennsylvania.
Absolutely, yes.
Well, I want to thank you both for joining me. I feel like I've got the right people at the table for this conversation. And, let's start with sort of the state of AI in CT today, because really AI is a big part of the future of everything going on in medical imaging, I think, today. And certainly in the area of CT, there's a lot of applications. So Dr. Noël, really to begin, what do you see as really some of the most meaningful applications of AI in CT imaging today? Where is it really making a difference in your clinical practice every day, or even at the research level?
I think as you said very correctly, we're at a turning point where really AI plays a role in every aspect. I mean, from the patient checking in to getting the CT scan to the diagnostic part. And I think right now we see a lot of motion where we bring things together. I mean, we're talking about CT here. So, we're bringing image reconstruction with deep learning together. We do motion correction in cardiac imaging, for example. And I think all these things bringing us a step farther and farther of getting the best out of the hardware and utilizing the things we can do. I think there's big steps happening right now.
Right, and you mentioned cardiovascular, and that's your area of expertise, Dr. Nagpal. Anything you might add, from the cardiovascular side as you think about the practical, impact of AI today?
Yeah, I think very well to the point that various simple things like that were core, I would not say issues with cardiac imaging, but something that was preventing the growth of our field was simple things like motion correction. Patients have to be beta blocked for getting CTs. Now with motion correction, at very high heart rates, we are able to get very high quality imaging. Same thing applies to doing it in pediatric patients in which the heart rate normally runs in like 120, 130 beats per minute. And in those patients, at one point, the CTs used to be very blurry, I would not say non-diagnostic, but with the limited diagnostic ability. We have gone to excellent quality imaging. So not only that, our reach of CT and the types of diseases we do CT in, the types of procedures for which various interventionists ask for CT, that has changed. On top of that, a lot of technological advances that have been possible are AI based in many ways. So for example, plaque quantification, which is one of the new and upcoming thing for the year for coronary CTs, is all based on AI based quantification of plaque. And that's the kind of things that are really moving the field these days.
Dr. Nagpal, are you seeing any of these tools kind of really helping you, from a acquisition perspective or motion handling, analysis, and even reporting?
Absolutely, like they are in every step now. So for example, almost every CT that we do, howsoever we do, all our images are enhanced in some way by AI, whether we call it peak or we call it DLIR or whatever name we can give it to the iterative reconstruction. These all have enhancements built in them. On top of that, you said, how are they helping in diagnosis? When we open a CT these days, I get a full gamut of what kind of things this patient does not have. So there is an AI algorithm that runs and says, okay, there is no PE, no aortic dissection, there is no rib fracture, there is no vertebral fracture. It almost is like you basically have something reading your scan with you. And what it does is that it really makes you efficient, that if you see a PE on a scan, as soon as you open, you basically go to the slice where it highlights the PE and actually look whether it is true positive or a false positive. And those kind of things are very applicable in terms of efficiency.
I would just add that we also see it from the other end of the procedure. I mean, when the patient comes in, the patient gets positions, how the protocols are chosen. All these things are much more driven by AIs than they ever have been. And I think we're really moving into a direction where standardization becomes possible, the workload gets better for people scanning.
Let's switch gears and let's talk a little bit about something new in CT, photon counting, right? I mean, it's been around a couple of years. It's really starting to gain momentum. We're even starting to see it move into sort of the community areas. You know, in your opinion, Dr. Noël, you know, what do you see are the sort of the, as this continues to gain momentum, what are the biggest challenges that we still need to sort of solve, whether it's technical or clinical or operational, as you think about the promises and the challenges of photon counting, CT?
Yeah, absolutely. I think we're actually in a phase where we see photon counting becoming more and more a topic. I mean, everyone, you can almost walk here everywhere and there's a lot of talk about photon counting, how great it is. At the same time, I like to say that it's a little bit like a green banana. We're not there yet. I think we all see the promise and we see like first signs of the promise, but I think there's still, from a technical perspective, as well as from a clinical operational aspect, things we need to address to really fully enjoy what photon counting can give us. I think it is interesting, we see very similar to the first topic, that also photon counting needs to work together with deep learning reconstructions. I mean, we see that if you apply deep learning image reconstruction to high resolution imaging, which I think is one of the #1 applications of photon counting, we're starting to see that we get actually another level of image quality. And I want to emphasize too that I think the high resolution is fantastic, but it's really a starting point of the story, because I think it's easy for all of us. You see images, they're much prettier, they give more details. Anyone loves them, you don't have to be a radiologist. I mean, we can ask a random person walking by here now and say, which image you like more? And they will say, oh, the one high resolution with deep learning is the one which is really cool.
From a cardiovascular perspective, sort of staying with sort of the promise and the challenges of photon counting CT, Dr. Nagpal, kind of looking ahead, what is the promise for photon counting in cardiac and vascular imaging, and where could it change maybe the diagnostic conversation that's going on?
Yeah. Regarding photon counting, I think it was yesterday, I was in a lecture and somebody pointed out that what they felt with photon counting when they see it for the first time was exactly what they felt when they got the glasses and they just did not know that they had they needed glasses. It was kind of a whole new level of imaging. And I think from the cardiac perspective, we work with smaller size vessels. Coronaries are usually 3 millimeter or smaller. And any kind of resolution improvements that you add on to the CT scanner really helps us find smaller diseases or diseases early. So what I think is our atherosclerosis detection is going to improve. Now, it also creates challenges. At the same point, I know we were talking about what advantages we get. Now, the challenge we get with this is that in cardiovascular imaging, so many of things are quantified. For example, FFR is a quantification of a flow reserve, or plaque is quantified, and there are therapies based on quantification. So I always feel if visually I can tell that these images are different, they are better, now do we need new guidelines for quantification, or are we going to treat based on the older guidelines? Or is the FFR going to be different in the patient whether you get a CT on a conventional EID scanner versus a photon counting scanner? I think those are the challenges we still have to figure out how to answer them going forward.
Let's transition to some new technology, multi-positional CT, something I believe is a new feature on some of the scanners, vertical and horizontal imaging. I'm going to go with you here first, Dr. Nagpal. What does this mean for you as a clinician? What opportunities does it open up, particularly in acute cardiac care?
The way I think of this is kind of in two folds. One is how it helps our workflows. The second is how it helps us diagnose some diseases better. So there are certain things that happen more physiologically when you are either sitting or standing. So for example, we look at lung diseases in a conventional CT when the patient is lying down. That is not our normal physiology. Our normal physiology is that we are sitting or standing good 2/3 to more than 2/3 of the day. So when the patients have symptoms, when they're sitting, when you lie down, their perfusion in the lungs and their ventilation completely changes. So opportunity with us is any disease that is actually more noticeable in a sitting or a standing position. So for me, the three areas that I personally feel are going to be very useful. One would be spine imaging. If you have disc diseases, if you have joint diseases, you want to look at the knee position now. Instead of doing a CT lying down, you want to be doing a CT standing up to know how is the knee actually working with the mechanics of your weight on it. The second thing would be hernia imaging. I think with so many hernias you can only see them once people are standing or sitting or with Valsalva. So you kind of have to do combination of those. And the third, in my opinion, is going to be lung imaging. I think a lot of physiologic lung imaging we are just not able to do with that. And the last thing I think would improve is throughput. For example, if you have a scanner in which somebody can just come in, stand, hold a handlebar, you scan, patient is out. Instead of having a table throughput of maybe 15 minutes, you can aim for 2 minutes of throughput through a scanner, especially if you're doing if you can batch things together, like if you have lung screening and you do 20 lung screenings, you just batch them together, you probably are going to do around twice the amount of scans that you can normally get when patients are lying down.
That's really interesting. It's a really, really good point too, because now you're talking about throughput, you're talking about efficiency in the practice. Dr. Noël, from a technology and research standpoint, from your perspective, how do you imagine a vertically capable C system might shift the kinds of CT exams that can be done now and into the future?
I think as a first point, I think it's important to say that building a system which can actually do both it's an engineering task which needs complement that is possible to do. I mean, don't forget CT systems are rotating very fast and you can do these motions. I think also it's a little bit of you think like, why haven't we done this already? It's like one of these moments where like, why didn't we do this already? With respect to where applications could change, I think there's things we do. I fully agree. Chest is probably MSK are probably really number one applications. However, I think there's also like functional things we, for example, do now in fluoroscopy. There is, for example, you drink under fluoroscopy and you show actually how the anatomical changes happen. I don't know if you ever tried to drink in an MRI scanner. That's not that simple, obviously. Doing it upright in a CT scanner is another example, I think things which we do in fluoroscopy or we do it very complicated in CT or MRI now will actually be much simpler, much more comfortable for the patient, and will increase the throughput at the same time. So I think there's a whole group of new things we potentially will find. And I think also I think we're in the start of a story. We're certainly not at the end of the story. I think we're just getting into what are all the things we can research and then clinically translate.
Well, we're covering a lot of ground here. I mean, this is fantastic. And I want to, as we start to think about wrapping up and bringing it all together, we've talked about, technology, resolution, speed, efficiency. All of these things are making a difference in your clinical practice. And this question is really for both of you. As you think about all these combined advances, how this all comes together, giving you higher spatial resolution, from these new detectors, cleaner, better images, using the deep learning construction, the aspects of AI. We talked about faster, more automated workflows. What, in your opinion, does the CT of the future kind of look like to each of you? And if you were to make a bold sort of statement, what changes do you think the clinician will feel first? Like where will the rubber meet the road? I'll start with you, Dr. Nagpal.
I think the CT of the future, the way I envision it, is that things would be automated more and more. From the patient being on the table to, let's say plan the chest CT, it would be auto-planned. It would be done the same way every time. I think consistency is going to improve. There is a lot of user dependence, even though CT is not a user-dependent modality, but within techs, we do get some user dependence. Same is true for our dictation templates to how the reports are interpreted. So I think what future would be is that everything from planning the scan to which reconstructions happen, how those reconstructions show up in the packs, to a standardized template and auto processing of most of the findings. I do not think it would probably go automated reporting completely, but most of it would be kind of predictated for you, and things would be much higher efficiency going forward with combination of all the things.
Dr. Noël, your thoughts on sort of the future of CT?
Yeah, I mean, I fully agree with the points you made. I think we will see workflow improvements, precision will go up, quantitatively, we will be much better because we're more consistent in what we do. I think those things, will happen. I think it's always hard to predict the future, right? Because if I could, I would probably not sit here because then I would, don't have to work anymore. But I think in your words, to be bold, I think what we will see is that patient care will get better and more accessible. I think that's an absolute must. And the other thing we can say now already is that with the things we're doing right now, we're getting ready for this. I mean, I think we're on the right path to achieve this goal, and I would see it there.
And that's actually where I wanted to close, in the sort of like getting ready for it, right? Because, institutions have to prepare for these. There's all this new technology, you're evaluating it, you're evaluating the vendors, you're evaluating the scanners, you're evaluating the technology and all the different components and how that'll work into your institution. And for various reasons, you choose to work with certain vendors, yeah. What guidance would you offer? What advice would you offer to your fellow clinicians, other health, systems, as they sort of prepare for this next generation of CT scanners that are available? Some of them today, some of them which you're currently using, but they may not be. What would you say to them? Dr. Nagpal, closing thoughts.
My thought would be one, the technology is something that by the time you get to the latest technology in a year, it frequently gets outdated. So I always say, one, you as a field in radiology, you have to be on the front end of technology rather than be on the back end. Like when you go and buy an iPhone, you should not be going and buying a 2-version older iPhone because it is cheaper. You should go and buy more recent iPhones. I would say the same things, and also a little bit of guidance should be based on what is your predominant practice. There are few scanners that do certain things much more better than other things. So for example, again, I'm in cardiovascular imaging field. A lot of our community hospitals do not have our best cardiovascular scanner, but when you come to access, we have kept those scanners at certain sites, both in outpatient setting as well as in inpatient settings, so that we can give very similar care, whether you are an outpatient or an inpatient. But at the same time, we kind of have managed it in a way that not every scanner is the same scanner, and some have higher use of a certain thing versus another thing. So that's the guidance I would say. Just identify what's your peak use, kind of try to offer everything, but not everything at every place. So just kind of triage which one would you do at a certain location.
Closing thoughts for you, Dr. Noël.
I would agree. I think knowing what you need is very important. I think often things are measured and say, I need XYZ, but if you really think about it, I need maybe cardiac imaging, I maybe need high resolution imaging. I mean, focus on the things the patients who are coming to a specific place need. I think that's an important part. And I also would say, I think the future is coming and things are changing continuously. So I think it's always good to be in the forefront, and when we lead, you can also shape the future, right? If you walk behind, you have less of an influence on what the future could look like. So that, I would encourage everyone to think about how we could lead in the new ways.
A fascinating discussion on the future of CT imaging. We've covered, as I said, a lot of ground here. I want to thank you both for taking the time to sit down with us here at Applied Radiology. Appreciate the time and your thoughts on this subject. I hope you have a wonderful rest of your RSNA experience.